Hello, everyone, and thank you for joining us for today's training, the third in our series on a transdisciplinary approach to behavioral health populations in primary care. My name is Rick Brown, and I'm the Senior Director of Communications, Membership, and Special Initiatives with the Association of Clinicians for the Underserved. I'll be your host for today's training. If you have any technical issues during today's webinar, please don't hesitate to reach out to me or to my colleague Josh for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to transform communities to advance access to quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more to support clinicians in the healthcare workforce. We invite you to learn more about us and membership with ACU at clinicians.org. Also, on our next slide, you'll see that if you're excited in more resources on behavioral health for community health centers and other institutions working for medically underserved communities, we encourage you to visit our behavioral health program page, where you can find archived presentations, upcoming webinars and events, and more. Additionally, on our next slide, you can see that registration is also open for our upcoming 2026 Behavioral Health Leadership Forum, taking place on July 29th in Washington, D.C., following ACU's 2026 conference. This full-day symposium will feature CE/CME accredited workshops, discussions, and more on best practices in behavioral health for clinicians and leaders at community health centers. We hope you'll save the date to join us, and our registration is open now. Please stay tuned for more details. Also, before we begin, I did just want to go over a few quick housekeeping items. First, we will be recording this session, and we'll share the recording and the slides with your team within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll also have a dedicated Q&A at the end of the session. Please also complete our evaluation at the conclusion of the training. It's tremendously useful to help us continue to improve the quality of our educational offerings. Lastly, I am honored to introduce today's speakers. So on our next slide, you'll see that Dr. Virna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the COO and co-founder of Zero Overdose, as well as a member of ACU's Advisory Council. She's a national expert in suicide prevention and collaborative care, a faculty member for Zero Suicide, and previously served for over 2 decades as the senior vice president for a large FQHC network in New York. Additionally, we're also honored to welcome Mallory Tominich. She is the Pediatric Behavioral Health Manager at Primary Care IPA, where she leads the implementation and oversight of integrated behavioral health programs across pediatric primary care practices. Her work focuses on expanding access to early behavioral health support by integrating services such as collaborative care, healthy steps, and parenting programs directly into pediatric settings. She works closely with pediatric providers, behavioral health clinicians, and care teams to improve early identification of mental health needs and strengthen care coordination for children and families. She's also passionate about advancing integrated care models that support both pediatric patients and the providers who care for them. We are honored to have both of our speakers presenting with us here today. And with that, I will turn it over to Dr. Little to kick us off.
Well, thank you so much. It's a pleasure to be here. Super excited to get a chance to talk about collaborative care. And I'm looking, and I know some of the folks who are joining us today. So for those of us who know me, I could actually talk about collaborative care all day. So we're just going to spend an hour. I will apologize a little bit if I have some background noise. Unfortunately, the quiet area where I was supposed to be today did not pan out. So hopefully that will be to a minimum. So we are going to spend the next hour talking about collaborative care. And what I really want is for this to be the place where you can get all of your questions answered. So if you have a question, put it in the chat. We're going to have some questions, time at the end for questions, but absolutely bring your questions, bring your comments. So for some of you who have been following the webinar series, we've been kind of working our way through thinking about your entire behavioral health population. So we spent some time recently talking about health and behavior intervention, sort of that one and done, or maybe our smoking or weight loss populations. We're now talking about measurement-based care and collaborative care. And so we're going to do a little bit of a deep dive there. We're going to start next time talking about some focus brief interventions. So again, really thinking about your total behavioral health population and how you could put some systems in place to care for that population. So I really just like to level set with everyone. So what is collaborative care? So collaborative care is an evidence-based model. It is the identification and treatment of behavioral health conditions in healthcare settings. So probably you've heard lots of different definitions, had lots of thoughts about what it is, but that is actually the official definition. So why would my health center do collaborative care? This is the biggest question. So I thought I would take it on right away. That way we could just put it to rest and we can kind of go on with the rest of our conversation. So I get this question most often, like, why would we do this when I can do traditional care and bill my PPS rate? And so there's lots of different reasons why you might do this. One is you're creating access for a broader population. And so I like to think about it, what if you had your population of diabetic patients and you said, listen, the only support we can offer you is 45 minutes a week with the depression care, depression or educate diabetes education specialist, and you have to come in every week for 45 minutes. A lot of people would bail, right? Because you want to try to do the right care for the right people. And so collaborative care gives you the opportunity to create access across a way broader population, not just one population who might want to come in every week. The other is that it really helps you optimize your staffing resources. So oftentimes people say, well, I can't find someone, I want to hire people who maybe aren't licensed yet, as an example. And also, because collaborative care is predominantly telephonic, you can hire someone that's in your state and not necessarily in your community. So it allows you a broader hiring strategy to fill some of the needs. Also, equality and UDS measures. We have a UDS measure for depression. Many of us don't do a great job of meeting that measure. Oftentimes, collaborative care is a little bit more rigorous, but you actually will get the help, support, and meet your UDS measure for depression. It is a really good way to introduce measurement-based care for behavioral health. If I had to guess, there are many of you who don't actually have any quantifiable outcomes for your behavioral health treatment. And so this is a really good way to be able to start doing that work. We also want to think about how we can optimize some revenues. People will say, well, I don't get paid for warm handoffs in my state because we still have some same day problems, or I don't get paid for that because I don't spend enough time. And so, or I don't get paid for the quick follow-up phone calls I want to do. Well, collaborative care, all of those activities I just talked about are actually included in the monthly case rate, and you're able to bill for that time. And also, we give some better support to some of our patients who are really at risk because we can talk to them every day and we can really give them the kind of support that they need. And that is actually sort of some of the premises that I talked about are where collaborative care started. So many of you have heard Project Impact or Impact that came out of the University of Washington. It was actually a huge randomized controlled trial, 1,800 patients, 400 primary care providers. And at that time, it was really seniors and depression. It has incredibly changed over the years to a much broader spectrum of ages and diagnoses. But either way, there's actually at this point over 110 randomized control trials that say, hey, this works. Like it's out there. People want the research. I can send you a ton of research supporting it. And there's a lot of non-randomized control trial research, like a lot out there now on pediatrics, rural communities. We've put a lot out this past year on suicide, women's health, ADHD for children and adults, bipolar. So a lot of communities and populations that we didn't really think of before. There's actually research out there that supports collaborative care as a care model for them. When we think about collaborative care reimbursement, in 2017, CMS passed dedicated CPT codes onto the Medicare fee schedule, so Medicare and Medicare Advantage. And then since then, the commercial plans had followed suit. So I can only think of two or three commercial plans in the country that have come to my attention that don't reimburse the collaborative care codes. And then right now, we're actually at 35 states that have the codes on their Medicaid fee schedule. There's a couple of others that don't have them on the fee schedule, but that the managed care organizations actually pay the codes. But that's where we are at this point. So for most of you on the call, you're going to be able to build these codes across your entire payer mix. And if you have any question about the state that you're in, then you can throw it to us in the chat and we can get back to you, or I could probably answer it in the Q&A. So when we think about community health center reimbursement, there's a couple of things that have changed. Many of you might have made decisions to not do collaborative care because you may have some high Medicare populations or you heard about this G0512 code. So CMS changed that in January of this year and they got rid of it thanks to some of you who helped write some letters to ixnay that code. And that really limited people for an hour of care. It didn't work. It didn't work for anybody. And so that is now gone. There are a handful of states that actually also adopted that code. Some of them have already gotten rid of it. So North Carolina, Washington, there's Texas actually just said we haven't figured it out yet, but we've gotten rid of the code. And so we really want to make sure that you understand that for your Medicare patients, you're using the regular CPT codes now. So again, that was a reason that some said we're not going to go forward with collaborative care. There are two states that have actually excluded community health centers from the Medicaid fee schedule codes, and that's Montana and South Carolina. And yes, we are actively yelling at those states, but those two are excluded. A lot of states pay outside the PPS, so there's actually precedent for that, like New York State, where Mallory is sitting as an example. So lots of good precedent for that as well. So what is collaborative care? This is a pretty picture of what it actually looks like. So we have our primary care provider. They continue to be the captain of the ship. We have a behavioral health care manager. We're going to talk about who that person is and what they do. But they actually get to interact with the patient in a very patient-centered way, mostly remotely. We'll talk a little bit about why that is. That's actually by design. And because of the monthly case rate, collaborative care is reimbursed in a monthly case rate. And so that person can be incredibly patient-centered and do what needs to happen with the patient without worrying about meeting certain time requirements. A registry is required because this is a population health approach. And then there's a psychiatric consultant. The psychiatric consultant does not see patients and they don't prescribe medications. They actually make recommendations in weekly meetings to that primary care provider or to that behavioral health care manager. And so their role is to be an advisor. So they can actually touch way more patients than if they were actually seeing them in person. And generally, they meet with that care manager about an hour, hour and a half every week, sort of depending on the caseload. And I can certainly answer questions about the registry a little bit as we go forward. There's only a handful of EMRs that actually meet the requirement for a registry, but there are lots of options out there for people. So, little bit more about the collaborative care team. That primary care provider, again, captain of the ship, they're going to be the one that maybe reviews a screening that came back positive or responds to someone who says, hey, I've been feeling so sad, I can't get out of bed. They're going to be the prescriber of the medications. They're going to do a warm handoff. And by a warm handoff, I don't necessarily mean that Mallory needs to be in the office, right? That we can say, hey, I work with Mallory. She's part of my team. She helps me care for my patients who are sad. I'm going to have her give you a call later today. But they work really closely with that psych consultant and that care manager. The care manager uses lots of clinical interventions, ones that we know work with the patients that we're caring for. They do a lot of self-management goal setting. They make sure nobody falls through the cracks on their registry. They're going to change it up. So if somebody's not getting better, we're going to switch it and we're going to switch it 2 or 3 different times. That psychiatric consultant is going to make the recommendations, maybe give some information on diagnostics, and they're going to be a pretty active part of that team. Now, I have noted here because you do have options that I wanted to call out. A lot of federally qualified health centers, community health centers say, we're going to build it. We're going to hire behavioral health staff. We're going to figure it out. Others say, you know what? We have lots of sites, lots of services. We have trouble finding people. We're going to contract it out and someone else is going to come in and do all of our collaborative care and they're going to supply the care managers and the psychiatric consultants. I'm glad to talk There are some health centers that have a hybrid model, some that contract it out, some that build it in, lots of different considerations. And so glad to talk about, do I build it, do I buy it, or I do both? And there is a guide actually that can help you select vendors that we can share out if that's something that you're interested in. Or we have a pro forma that we can do with you to help you figure out the finances if you're building it internally. So let's take a moment and really go through what some of the core principles of collaborative care are. First of all, this is incredibly patient-centered. So many models say they're patient-centered, but this truly is because I can switch up patient care all the time. I talk to Mallory every single day if I need to. And we also want to make sure we're serving our whole population. So it's not just the people who need counseling, it's going to be everybody who has a diagnosis that we're including in collaborative care. It is incredibly treat to target. So if someone is not getting better, we are going to do something. So if somebody's not getting better on their PHQ score by more than 2 points over the next, over the first month in care, we're going to switch up treatment. We're going to use the evidence-based practices that work. I'm going to use cognitive behavioral therapy. I'm going to use DBT, all of those BTs, right? I'm going to use them in treatment. I'm going to be accountable to the entire population. The average duration in collaborative care is about 4 to 6 months. And we see 2 to 3 more times patients actually engaging in collaborative care than more traditional behavioral health services. So this is probably the most important slide that I'm going to show today in terms of understanding the model. And this is where a lot of people, I call it the drift. And Mallory will laugh because I say, oh, we're drifting, right? We're drifting away from the model. And it is so important to understand the treatment choices in collaborative care. And I'm going to sort of go through from bottom to top. So you kind of have some idea. So the first is symptom monitoring. And sometimes people say, well, aren't you monitoring symptoms for everybody in collaborative care? The answer is yes, but it is possible that that's all I do. So if I call a patient and they say, you know what? Actually, I'm good. I don't think I need anything. I'm good. I can say, you know what? It is really important that your provider know how well you're doing. What I'd like to do is call just maybe once or twice a month, ask you some questions. We have a way to measure how you're feeling, like we measure your blood pressure, and that way I can keep your provider in the loop. If that's all I'm doing, that's symptom monitoring, and that is totally appropriate treatment choice in collaborative care. I may not do anything else. Am I going to chat them up when I call them? Yes, but I may not do anything else. The other one is medication support. And people don't have to be on medications to be in collaborative care, but maybe that's all I'm doing is giving someone, it's really hard to take a medication every day. What do you think you might need to do in the morning? Oh, we're going to put it by the coffee pot. Let's see if that works, right? So I can only be in medication support. Behavioral activation is probably the largest one where I would say most people fall into behavioral activation in collaborative care. And this is like a goal setting. So I teach a skill, I follow up in a day. What's something you could do today or tomorrow to feel less sad? We set a goal, we pick something, I call you the next day to see how it went, and we continue to build on that. And so that actually is where most of your people will fall. And then there's talk treatment or therapy, which is actually possible and happens in collaborative care. And somebody could be in talk treatment every week or every other week. Or we could say, you know what, sounds like you have a lot going on. I'd like maybe we schedule a time to talk a little bit longer this week. I could be in talk treatment or therapy for just that 1 week. And the thing about these treatment choices is I can be in one or all of them, and it can change from week to week. And that's why nobody's schedule in collaborative care should really look the same because every patient is going to have their own individualized plan and they're going to be in these different treatment choices. And so if you're doing collaborative care and you're saying we see people once a month or we see people every 2 weeks, then you've drifted away from the model, that patient-centeredness, and really embracing the treatment choices. It also gives people options. I could say to someone, you know what? your spring break is coming up, your schedule is going to change. Oh, yeah, I'm going to be home. I'm going to be with my family. I'm going to want to see all my friends. You know what? Why don't we just check in once while you're home for the month? And then so we can switch things up. Or, you know what? I'm going to be home. My family makes me crazy. Maybe we could schedule some other time to talk. So people can be very fluid in those treatment choices, and you can switch it up all the time. So, who are our collaborative care populations? So, our collaborative care populations are anybody ages 6 and up. A lot of people will ask, but 6 and up is really where we generally start collaborative care. So, certainly our mood disorders, depression, and anxiety, and I like put a big umbrella there because lots of things fall under depression and anxiety, right? Substance abuse. PTSD and bipolar. Certainly lots of new evidence out there now. I put PTSD a little bit separate because sometimes people think, oh my gosh, somebody has a history of trauma. They have to be in more traditional care. We actually find that that is the opposite. A lot of those patients don't engage, but they will engage in collaborative care and have really nice treatment success. And then ADHD, both for kids and adults. So, a couple of misconceptions I want to take on a little bit. Collaborative care is not a lower level of care. And in fact, if you start doing collaborative care and you use this language, I guarantee you, I will bet you money that you will regret it. Because then if you hire people into the role, they're like, well, I do a lower level of care. Or we're going to send people there, it's a lower level of care. Or we'll put them there till we can get them something else. And that is actually a really big misconception. It's evidence-based care. And so not one evidence-based may be higher or lower than the other. And also, we want to make sure that we understand collaborative care is clinical behavioral health treatment, right? So that we are actually treating people's behavioral health diagnosis. And we should not consider it to be a bridge to treatment. And there are people who maybe need other care. Like we saw someone the other day, or Mallory, I don't know, where with the eating disorder, substance use treatment, right? We will send people to those and we can bridge them to that, but it is not consistently a bridge to other care, which oftentimes is something that you hear. So, a couple things about how we think about behavioral health treatment. We have actually learned that treatment is better in doses. And so sometimes people will say, well, I need therapy or I want to be in therapy. So, you know what? We've learned a lot about getting people better. And what we've learned is that treatment is better in doses like medication. So, you're going to get a couple of doses of me a week, right? Like, we're going to talk to you a couple of times because we've learned that's what's more effective, like therapy in doses. We want to make sure that we're giving someone treatment successes. So we want that to happen right away. And we're really offering that broad range of care, making sure the right treatment is going to the right patient and that we're really actually being very patient-centered. So, some thoughts about staffing. So, CMS does not require licensure. However, some states do require licensure. And I have an updated list if people want access to that. And because the care managers provide treatment, they do have to be licensed in some way or pending licensure or master's level, or someone, sometimes people say, well, can nurses? Yes. Somebody who's really able to do treatment. There are some treatments that are in scope for bachelor's level, but for the most part, most of the care managers around the country are master's level folks. Psychiatric consultants can be nurse practitioners or physician assistants. There are some states who don't have full prescribing practices, and so there's a little bit of drama there. But for the most part, a lot of the psychiatric consultants are NPs or PAs. And either way, the providers, if they're licensed providers, they should be licensed in the state in which they provide care. And one of the things that I really like to do is hire master's level students or have them be in a field placement. And I know, Mallory, if you want to take a couple of seconds, I know your organization has done that. How has that worked out? I think you've hired some of them into jobs.
Yeah, so what we do with our sites, for some of our sites that are interested in collaborative care, but since we are part of an IPA, we're independently owned, so our practices don't have like accessible money just to hire a new staff right away. what we do is we actually made some relationships with some universities around Buffalo, and we take graduate level social work students and we put them into the offices that are interested in collaborative care. So we actually have an intern practicing as a behavioral health care manager in the collaborative care model with myself or one of my coworkers like supervising because it does meet all the metrics of a graduate social level clinical year student. So it's not their first year, it's their second year or the advanced level. And then what actually happens after that is with students, and I apologize if there's any students on the call, but it's technically kind of free labor for the practice. And what happens after is we're generating reimbursements and we're generating money as they're delivering collaborative care. So and as their time with us comes to an end, we were able to make some revenue. And then a lot of our practices, probably I would say 90% of our practices that took the internship model, hired the intern right out of school, and they were able to move into a full-time position because they were able to show that like this is able to produce income. So we actually have probably 6 of our sites that took that model, and we were able to then keep the longevity of the program because they saw like, hey, this works and money's actually coming in that way.
Hmm. What a great model. Yeah. So yeah, works really great. So let's talk a little bit about training. It is pretty impossible to do collaborative care without training your primary care teams. Remember, also, these are primary care codes. These are not behavioral health codes. And so it is super important to remember that to let provider know because they are the billing providers. We want to give them really clear language on the handoff. And I kind of said it before, hey, I work with Mallory. She's part of my team. And we want to not use words like therapy. We want to not say counseling. We're just doing a handoff to someone on our team, and it's our entire population, everybody with depression, anxiety, ADHD. Not like, oh, I have this, I had a provider the other day say, well, I let them know about the depression program and they are not interested. And so I'm like, well, it's kind of not a big surprise, right? So like, how else can we, use some of the language? And it's their entire population. And so oftentimes what I did the other day with the health center is we ran a report of all the patients that had gotten prescriptions for depression medications in the last 6 months, either new or refill. Then we ran a report of everybody who had a positive PHQ in that time frame. Then we ran a report of everybody who had depression on the problem list that had been seen in that time frame. And then we ran a report of everybody who had a reason for visit depression in that time frame. And some people were on all of those reports, but a lot of people were just on one of them. And so what we really did was work to clean up that population. And what providers started to see was like, hey, wait a minute, I've got this big population of people, and I don't know how a lot of them are doing. I don't have updated scores. I'm not really sure about the diagnosis. And so that was really a good way to sort of get people and say, wait a minute, I need to really think about my population of patients with that behavioral health diagnosis. So I want to take a minute and just go through the billing. There's really only a handful of CPT codes that apply for collaborative care. And again, these are primary care codes. They are not behavioral health codes. And so in the first month is this 99492. We're outreaching to people. We're getting them engaged in care. And remember, it's a monthly case rate. So we'll talk about what we can include in these monthly minutes. There's a second month or subsequent months, this 99493, which is 60 minutes per calendar month. And then we have what we call this add-on code, this 99494, which adds 30 minutes. So now CMS, Medicare Advantage, will pay up to 4 of those codes. States vary by whether they pay 2 or some of them have not yet followed with CMS. Some commercial plans will pay 2, others will pay unlimited. So you're going to have a little variation with this code, but generally everybody pays at least 2, which means that there's about 2 hours of care a month. And quite frankly, if you have more than that, then you maybe have drifted from what you should be doing, spending maybe too much time with people or on some of activities. And then there's this G code for 30 minutes per care. So Medicare and Medicare Advantage recognize this code. Some states do not, and some payers do not. And we have a list of the ones that actually do. But it's a code to be able to know about doing some of this work. So what is included in these time-based inclusions? The psychiatric consultation. However, your psychiatric consultant gets paid out of these codes. They don't bill directly, but it only gets billed one time. So what that means is if I sit with a psychiatric consultant and I spend 10 minutes talking about Rick, then only 10 minutes for the care manager counts. It doesn't count 10 minutes for the care manager and 10 minutes for the psychiatric consultant. Any discussions, case reviews with primary care doesn't change how they bill at all. In fact, maybe they're adding to their E&M codes, but nothing changes for them in terms of billing. Anytime the care manager is updating the registry or working in the registry, telephone. And most of collaborative care is done by phone. It was designed that way. It was meant that way. It had nothing to do with COVID. When we first started doing this work in 2002, it was mostly by phone. And that's because a lot of it is much shorter follow-up work. And that just works better by phone. And also, I do activities with people on the phone. Let's open your window blinds. Let's stand outside and take some deep breaths. Let's, do some mindfulness. Any discussion with collaterals, wives, husband, parents, in-person visits, if you are not billing them. So if you're not billing them, then you can count them. And most of the time, unless your state doesn't pay the codes, I don't recommend splitting, and making sure that the exact time is documented. The other thing that's important to know, and I always call out here, case management or those concrete services are carved out. The transportation, the housing, the sliding fee scale, the insurance stuff, all of those food banks, all of those concrete services are not included in these codes. These are clinical, diagnostic, treating behavioral health conditions. So those concrete services are carved out. I know a lot of community health centers will say, well, can my community health worker who does a lot of this stuff, can we use the collaborative care codes? The answer to that is no, all of these services are carved out. So what are some of the things that we want to try to track? So first of all, the caseload, about 90 adults and 75 pediatric or geriatric is the average sort of caseload for collaborative care. We want 90% of our time to be attached to that billable episode, and we want 90% of our episodes billable for the month. So if I have 90 patients, 81 of them we want to be billable. We want to track how many people got a referral and then how many people had a billable first month episode. And then we want to track how many people then had a second month episode because then we can really track engagement. And what we don't want to do is track productivity. I get calls from care managers all around the country and they're like, I really love doing collaborative care, but my health center keeps telling me that I have to see a certain number of patients and they're tracking my productivity. And because of the monthly case rate, productivity is actually meaningless because you're not billing those individual visits, right? You're billing the monthly case rate. And I can tell you, if you have a care manager that has a caseload of, 75 to 90, and 90% of their time and 90% of those episodes are billable, they're fine. They're generating revenue. You don't have to worry about it. They're doing what they're supposed to do. And so I don't think you worry about it. And Mallory's actually going to share some of the financing and some of the work that they did and what they actually saw. So a couple of things we've learned about a collaborative care launch, build it or buy it, you have to make a decision. Do a pro forma right up front. Understand the finances. We know Mallory will tell you day one, I say, hi, my name is Virna. I pull up a pro forma and that's what we do because I want you to understand what the finances are. How many people do you need to have before you're sustainable so that we can make that decision? We're doing provider trainings before we launch so that they understand it and go big or go home. We're not going to try one provider. If you're going to launch a practice, launch a practice. And then what we do is month 1, 30, month 2, 60, month 3, 90, because what we have found is most practices then can be self-sustaining month 2. And what we've also found is then practices are good to go. The providers get what it is, the care managers get their groove, and they seem to be pretty good to go. And oftentimes when I hear that we tried collaborative care, it didn't work, it's because we didn't launch it well. And then we go to the place that I have on the bottom here. It's a terrible place to be, and you never get out of it. It's the land of perpetual launch. And if you land in the land of perpetual launch, you will be there for a really long time. We don't want you to be there. We want you to launch it right. And so a lot of times I've known practices that have literally been launching collaborative care for 10 years. And so we don't want you to go there. We want you to do it right from the start. So what are some of the biggest mistakes? Provider referrals only. I'm going to put a collaborative care manager here, and we're just going to depend on provider referrals. You need some population health approaches. You need something a little bit different. The other problem is oftentimes behavioral health is the lead. Love that. I'm a behavioral health leader, but it really needs to live in primary care, that there needs to be primary care leadership involved and engaged. And also what never works. And literally in 1,000 implementations, I can tell you it maybe worked a handful of times is splitting behavioral health. So I get people, they call me, we want to do collaborative care. Wonderful. And they introduce me to a wonderful behavioral health provider. And they're like, we're going to have them do collaborative care half the time, and we're going to have them do traditional care the other half of the time. And just like Mallory shaking her head, that does not work. It does not work for a dozen reasons. People don't like to be split like that. The schedules don't work. It's hard to track metrics. The clinical brain has to be in two different places. And also, if I have one side where I have to have a registry and be held responsible for outcomes, or I can just sit and talk to people, I'm going to go with the just sitting to people, right? So human nature and people end up very small caseloads, and oftentimes it doesn't work. And so we want to make sure all of those things are sort of in place, so that you have them, and then that's something that you're able to do. So Mallory, I want to turn it over to you and just give you an opportunity to share what you've actually been doing, and then we'll take some time to answer some questions. If people want to put some questions in the chat, that way we'll have them and we can kind of go from there.
Yeah, thank you. So to kind of piggyback off of what Virna was saying, first I just kind of want to introduce what primary care IPA is so we can kind of get the idea of where we're coming from with all the financial stuff I'm going to get into. So primary care IPA is a physician-led and physician-governed organization. It was created in 2019. A bunch of primary care doctors came together that had the mission of staying independent, and it's kind of just grown from there. Right now, we are at 20 primary care offices across Western New York. Again, all physician-led and physician-governed. So we really, there's no additional money coming in anywhere. We're not part of a bigger health organization, no hospital organization, no federal organization. It is just us kind of, we're mighty, but our physicians are mighty, small, but mighty. So we really, one of the initiatives that with the IPA, they wanted to tackle, there was a couple of different things. There was pharmacy issues, there were some coding issues, there were some quality issues, but behavioral health really was the biggest one after COVID, and probably even a little before. We saw that everyone started going to their primary care offices with behavioral health concerns, especially pediatrics. Our community resources were flooded very quickly and couldn't keep up with kind of the need. So then everyone went to primary care, and these offices, again, we really couldn't sustain anything without breaking the bank. We've tried building relationships with community organizations that we're supposed to like expedite our referrals, and that failed. We tried embedding outside therapists in that belonged to an agency, and that just kind of failed. So in 2023, we met Virna and collaborative care. And since then, so we started with one practice in 2023, and we've grown with collaborative care. So we've implemented it now in 13 primary care offices, 9 pediatrics, and 3 adults, family medicine offices. And I know the math isn't mathing here because one of our sites just kind of got bought, but it does count as 13 offices that we did embed in. So it's still 13 physical sites. And then in 2024 to last year, 4 of our pediatric sites were actually awarded the OMH grants for the implementation and like sustainability of collaborative care, which we'll kind of get more into as well. last year, the IPA actually had a national white paper that was written on our success. It was written by Virna and her team, and it's called the Successful Collaborative Care Model Implementation, which I'm sure that we can share sometime if people want to read it, if that's okay, anyone interested. But this article really gave us the first opportunity to take all the data that we've been collecting and throw it out there and see, like, let's see, like we knew we were doing good work, but we're like, let's see what has really been going on. So some of the results that we came up with was when the model is implemented correctly and within the collaborative care parameters, because again, this is not traditional therapy, it's different, so it has to be done correctly for that success, kind of what Virna was touching on. We saw financial sustainability with our practices within the 90 days, and that goes back to Virna's saying like the 30, 60, 90 of building up the caseload. So the caseload around 70 to 80 is achieved. And then after 11 months of doing that, we actually reached a surplus of 30.4%. And this size shows that the program is financially sustainable, but it not only pays for itself, but it also generates additional resources that can then support like expansion, staffing, or reinvestment into patient care. And with these offices, again, being independently owned, it was like we struck gold almost, and then more and more kept buying in. And just for context too, like, I mean, primary care and healthcare programs, we simply aim just to break even the first year. So again, the surplus indicates like this type of model is performing well above that threshold. Clinical outcomes wise, I mean, because yeah, like billing is great, but what are we doing for our patient care? So clinical outcomes over a 12-month period, we actually saw an 80% reduction in depression symptoms, and then a 60 to 70% of reduction in anxiety symptoms across pediatric and adult patients. And it really was just like incredible. This got more provider buy-in, and then again, we were able to continue just expanding into other primary care offices. With all of this revenue that we generated, we were actually able to come up with the conclusion that there's a potential $5 million in cost savings in this, because with collaborative care, since we implemented, we see a huge reduction in emergency room visits and hospitalizations. This is a reduction in like crisis services. We saw somatic symptoms go down. We now know that anxiety and depression symptoms can look like somatic symptoms, and people with heart palpitations, racing hearts, this and that, we're going to the ER. And then also, just like I said, those crises moments, we're able to frequently touch with these patients. So an overall reduction in emergency room and hospitalizations. We saw a decrease in specialty referrals. So cardio, neuro, GI was huge. We saw a lot of less of these referrals going out, and we were able to keep these patients in-house in collaborative care, targeting these specific symptoms. And then with collaborative care as well, that psychiatric consultant rate, we weren't referring people out to psychiatric services because our primary care doctors are able to prescribe and manage the medication in primary care with the help of the psychiatric consultant. So we saw a huge boost in medication adherence as well. Again, all keeping that in primary care, which is what primary care is. We want to keep it alive. And then I broke it down on the next slide. If we want to go to the next slide, just a little more. Again,
also, just to jump in, you actually have a shared savings agreement now with one of your payers.
Yeah, I was going to get to that. Independent
which
health.
is a huge deal. Oh, yep. Well, I don't want to steal your thunder. Yep.
No, you probably know more about it. I'm just a behavioral health person. There's a lot of logistics behind our contract negotiations, but I do kind of touch on that. So with this article, we were able to break it down a little bit because we're like, let's see what we're really doing. Because there's the break-even point, but then there's also like, let's make this longevity and like, let's make like sustainability from this. So between our adult practice, we saw a break-even point being 52 patients and a pediatric break-even point being 53 patients. And as Virna mentioned, like the caseloads we can see are up to 75 to 90. I actually have a care manager in peds that she's a rock star and she fluctuates between like 90 and 100. So it is definitely doable, and it shows like the average monthly billing revenue within the 90 days. We decided to break this down even further. So this is some data from our Wheatfield Pediatrics. Like I said, one of our care managers who really just kind of took off with this. After 11 months, that's where that 30.4% surplus came in. And now they are rocking and rolling. So again, not only is it sustainable, we look at generating additional income. And for independently owned primary care, or just primary care across the board, Who doesn't love that? I also think that this was a really good program too, because of course, like patient outcomes, doctors, medical staff, we want to prioritize the patients and how to help the patients. And we've been able to touch so many more patients live, being able to handle behavioral health in primary care, that now we have huge provider buy-in. I feel like anytime we implement, there's always just a little bit of provider pushback, but once they see it going and like generating revenue and just the patient outcomes and the symptoms decreases, they're like, oh, this like really works. So because of all of this data as well, kind of what Virna mentioned, independent health is one of our big payers that we've actually paired up with, and now we have like the shared savings with. We've actually dabbled with some of our payer contracts. We have like a quality project now with two of them that shows like how able and how quick we're able to turn around referrals. So for referring someone out in the community, it's a 2 to 3 month wait now. If it works out, we have about a 48 to 72 hour turnaround. We're able to get patients in and seen, and maybe just like that initial assessment within that time frame. So we're able to show and document that like we're able to get people in quicker in this program. And I do know that like moving forward, we're also our executive director is looking at kind of bringing this into more of our insurance contracts as well, because the data is there. It's working. I don't know, Vern, if you have anything else to share on the logistical insurance side of things.
No, I think that's wonderful. And I think that's what we're seeing across the board. There's so much data there now around the
Mhm.
total cost of care savings for collaborative care. Like it's out there from multiple state blue plans. There was a national report recently. And so the data has been pretty significant in terms of showing a total cost of care for patients that were or are enrolled in collaborative care.
Yeah. And also it's really good to target like Medicaid patients as well, because again, community resources, there's far and in between places that we can refer people
Hmm.
to, and being able to bill like Medicaid directly, it's more affordable, and it's easy access. Like Verna mentioned, it's
Hmm.
primary care code. So instead of a patient being billed for every single visit, like in a traditional therapy, it's a PCP copay that they get hit with once a month. So we have patients that
Hmm.
get billed if they have a PCP visit of $10. Boom, that's your collaborative care. Again, it's different across
For the
insurance.
month. So for
Yeah.
those commercial plans for Medicare, I could be paying $10 for a month of treatment instead of $30 every week or
Mm-hmm.
5 times a month. And so it makes services accessible and affordable for a large percentage of your population. Yep.
Especially in this economy, it does. People,
Yeah.
that's a huge buy-in. And then just being able to frequently touch with patients over the phone. It seems that no one has like the time or willingness to want to come into an office for 45 minutes to an hour and talk face to face about X, Y, and Z. It's like, how are you doing now today? What can we do better to make like the next couple of days go better? And I'll call you on Friday to see how those skills went. So we really do see that there's longevity to this, and we actually have behavioral health has kind of taken over the IP, and we actually have the goal now that we want collaborative care in all of our IPA sites as we continue to
Hmm.
expand as well.
And I think you brought up an important point. We know in collaborative care, it's the number of contacts, not the amount of time that really dictates outcomes and engagement. And a lot of practices that are doing this really well, we see 85% of the referrals engage in care, which are incredibly high numbers for, behavioral health engagement. And someone asked in the chat, well, what language do we give providers? I literally say to them, I work with Mallory. She's part of my team, helps me care for my patients who are sad. I'm going to have her give you a call and then make the referral. That is, and you've already talked to them about a potential diagnosis, reviewed a screening tool. That's actually super appropriate to be able to do that. And sometimes people will say, well, what about a copay? What I will do with people around the copay is I don't actually tell people right up front. I actually maybe say, what could you do today or tomorrow to feel less sad? We set a goal. And then I say, you know what we just did is part of your insurance benefit. Today, when you came in to see the provider, you paid $20. That would be for the month of us working together. Usually we can get someone better in 4 to 5 months. And then someone can be in or out on a copay. So that
Mhm.
generally works the best.
Mhm.
So we have some time for questions. I know, I think there were some other questions in the chat, so maybe Mallory and I. So one of the things to get their buy-in, what do we tell patients about collaborative care? I actually don't tell patients about collaborative care. Um, and I know this feels, people say, well, don't you tell them about collaborative care? Absolutely not. I call and I say, you know what? My name is Virna. I work with your provider, Dr. Smith, and I could see you were in here earlier today and you talked to her about how sad you've been feeling. Tell me about sad because people want to get better. And that is actually where I start. It is, I don't generally talk to people about what collaborative care is. It sort of doesn't come up, quite frankly. And I don't necessarily think it's a good, and if we spend a lot of time telling people what collaborative care is, a lot of times what we do is we have these scripts that tell them what it's not. It's short term, it's not therapy, it's brief treatment. People don't really understand what that means. And so then they're like, oh, I don't know, I think I'm out, right? And so we want to, I don't necessarily tell people what collaborative care is. And people are just really excited about getting better. And what we know is generally in collaborative care, we talk to people 2 or 3 times a week 1, week 2. That's generally what it looks like because the more contacts you have with people, the more likely they are to engage in care.
Yeah, I see a lot of that in like the adult clinics. They're like, okay, great, this is great. I in the peds clinic, I do see some parents being like, well, who the heck are you? And like we kind of like briefly explain it, just like Verna said. But once it's like, oh, like that's it, and they hear about like if they ask about like billing and it's we explain it, like it's really just such a bought in process. And people kind of find that like hard to believe until they see it. Like people are just like buying it. They're like, okay, perfect, help my kid. Oh, perfect. Over the phone, they have their own cell phone. Just call them directly.
Yeah. And also you can try things, well,
Mhm.
let's try making the lunches at night and then let me call tomorrow, see how that went. Well, we didn't really have time or this happened. Okay, let's try something else or let's do something
Mhm.
different. And so those are, you can try a skill, maybe you're just gonna be in the same room when you're giving information to your child, or maybe you're gonna try to do something outside or whatever it happens to be. Those small goals and that follow up are really what makes the magic in collaborative care. So there's a question here. Might insurance providers hire care managers that primary care doctors can connect with? So that tends to be a different model, and it tends to be ones that are focused around chronic illnesses. So like your diabetics or people that might be on a high utilization list. So that tends to be really different than what we're actually doing here. This care manager and this psychiatric consultant are part of your team whether they're remote or whether it's contracted or whatever, they are part of your team. I know we have like 2 or 3 more minutes for questions. Um, you are so welcome. Oh, so there's a question here again about the care managers. So care managers again don't have to be licensed. And also, these are primary care codes. The behavioral health providers are not the billing providers. So we don't have to credential them with all the insurance plans. We don't have to do any of those things. And so if I hired someone today to do collaborative care, I could start billing this month for them. I can start billing for their services right away. We don't have any of those loopholes. We don't need behavioral health authorizations. We don't need, to get somebody credentialed with each of the plans. So that actually makes this way more efficient. And also, I could hire people right out of school before they're licensed, and then if it takes them 3 months to get their license and it takes them, whatever, that's fine. I can still bill the collaborative care codes. Uh, Okay. Well, I know there's folks here. We are more than happy to answer any other questions. So if you have, um, oh, how do you pitch this to a PCP clinic? I worked on this for over 10 years and no clinic was interested. Um, I mean, Mallory can chime in here also. I actually find that it's helpful to tell people, listen, you have all of these patients that you're caring for now. A lot of them aren't getting to the care they need. They're the ones not going to the referrals, not doing some of the health things. We know how to get them better. We can actually help you. I would think of it like a warm, fuzzy blanket around you to help you care for your patients that are feeling sad. And I also run reports for them and actually show them, hey, you've got hundreds of patients that you have on meds that you don't know how they're doing, right? That you don't have current scores, you're not monitoring symptoms, you don't know if the medications are working. And so that's often helpful. I actually find that it's pretty easy. Where I sometimes still see some pushback, like women's health clinics where providers say, oh, I'm not prescribing, I'm out, I'm out, I'm out. Or a cardiology site the other day. And so I don't push that ice because a lot of people on in collaborative care are not on meds, and particularly in the women's sites then I say, okay, a lot of women are coming in, they're already on meds. So now we can have the psychiatric consultant tell you what the impact, can they stay on them during pregnancy? Can they stay on them while they're breastfeeding? You can get the consults, you can do that. And so I kind of just start there with some of the women's health practices, and that tends to be a good place to go.
Yeah, and I think there's a big like fear of this is like providers think, and this is what we saw in some of our clinics was this is another thing I'm going to have to do, or like another thing I'm going to have to worry about and manage. And it's once they get someone in there and they're like, oh, this actually saves me about 5 to 6 minutes like per well visit or per physical because I can bring someone in for a warm handoff, or I can have someone give them a call later. So I think it's just like showing like data as well, now that we have a ton and then just reinforcing like this is something that's going to take off like a good portion of the
Hmm.
behavioral health work on you as well.
Yeah, absolutely. Um, and I honestly find a lot of practices now know what collaborative care is, and they're like, yeah, bring it on. Yeah.
Hmm.
Yeah, for sure. Bring it on. Yeah. And it's important to find the right care manager too. I would say, Mallory, somebody who worked in an emergency room or worked inpatient or did ACT care, or somebody like people say, well, shouldn't I hire somebody really experienced? The answer is no, because a lot of times they're so stuck in like traditional services and using the psychotherapy codes, it's very hard to move them
Hmm.
away from that. And so it's actually better to have someone that is newer, and they're getting double supervision because they're getting the psychiatric consultation. So they meet with that person all the time.
Hmm. That's exactly why we do the internship program and then try to snag the students too. We've tried dabbling with staff that came from like clinic or like that have been experienced for 20, 30 years, and we just kind of can't break that traditional therapy mold with them for them to understand it's more frequent touches and like the brief interventions. So we do see not that they're less experienced, but less exposed, less exposure individuals tend to work out longer and kind of adapt to the model a little better. Well, a lot
Mhm.
better.
And can engage people and can, call people and just say, hey, tell me about SAD, and
Yeah.
just, have the conversation. Okay. Well, we are at time. Mallory, I really appreciate you joining today.
Thanks for
You
having me.
you and your organization certainly rock stars. I mean, just clinically, financially, really show everybody how it's done, and also in small practices and medium practices. So like it can happen, it can be self-sustainable, and work out really well. So thank you everyone for joining today. We definitely
Thank
appreciate your
you.
time. Please reach out to us if you want any state-specific information. We're more than happy to share it or answer any questions. Or if you say, you know what, this collaborative care thing sounds good, and you want us to jump on a call with your CEO, CFO, clinical leadership, we are more than happy to do that and answer any questions. So, please feel free to do that.
Yeah, thank you.
Well, thank you, everyone. And I wish everyone a wonderful day.